Very good morning. This study was part funded from a research grant support from Alcon Laboratories. So the purpose of the study was to evaluate the visual outcomes following implantation of a non-diffractive extended vision IOL in patients with pre-existing early dry macular degeneration. With more and more use of extended depth of focus IOLs, there is a trend of pushing the limits of and choosing them even in eyes with some retinal comorbidities. So that was the main aim. So it was a prospective interventional case series done at Raghudeep Eye Hospital, Ahmedabad and Jaipur, and all patients above the age of 40 years undergoing cataract surgery for non-traumatic cataracts were included, and all eyes had a non-diffractive wavefront shaping extended vision IOL Vivity in this case, and based on the amount of astigmatism, it was either a spherical or a toric Vivity. Patients with uncomplicated age-related cataract were included, but most important was that early AR, dry ARMD was defined objectively by the AREDS2 study criteria, which means multiple small drusen's less than 63 microns or few intermediate drusen's less than 125 microns or pigmentary changes at the macula, and this was defined both on OCT and clinical fundus photography by a trained retinal surgeon. Primary outcomes were a monoocular corrected distance visual acuity at 4 meters on the ETDRS chart, and the secondary outcome measures with monoocular unaided distance visual acuity, monoocular uncorrected distance and uncorrected and distance corrected intermediate and near visual acuity at 66 and 40 centimeters. The demographic profile was as expected. Average age was, mean age was 68 years, and equal distribution of male and female in right eye and left eye. And the part to look at is that 63% of patients were implanted with a toric version, which means we are correcting as low of astigmatism as can be corrected in most situations. Coming to the results, the distance visual acuity uncorrected was 0.12, which is about 6.7 by 6 by 7.5, and the corrected improved to 6.6 in almost all cases. The uncorrected visual acuity for intermediate and near was also quite good, 0.25 for intermediate and 0.23 mean for near, which is around N8 to N10, N8 parts to N10. The near add needed at 40 centimeters, the average near add needed was 1.36 plus or minus 0.18. So average was between 1 to 1.5 near add was needed in all cases. Most important part was that since the macular function is already affected with age-related macular degeneration, what we wanted to see was that with the change in the optics design and the light spread distribution, does it affect the contrast sensitivity? And we checked it at different cycles per decibels, cycles 3, 6, 12 and 18 with glare and without glare in photopic and mesopic conditions. And what we found was that the values were not different from what you would have in a normal contrast sensitivity of a normal eye. So that was the most encouraging part, that it doesn't deteriorate the contrast any further compared to a monofocal IOL. There are now some encouraging early publications. Mainly these were retrospective studies showing encouraging outcomes of the specific Vivity IOL in eyes with subtle macular pathology. So I think in our study also what we found that the accuracy of Vivity had a very good distance visual acuity along with intermediate and near visual acuity, most importantly without degrading further compared to a normal virgin eye in patients with early dry macular degeneration. And the clinical implications, I think what we can judge from here is that it can be considered in select eyes with early dry macular degeneration. The visual potential, of course, needs to be evaluated, and if you find that the visual potential itself is suboptimal, of course, counseling is very, very important. But at least this particular kind of EDOF IOL doesn't seem to cause further deterioration of visual acuity or contrast sensitivity. Our personal experience is with this kind of EDOF technology. I'm sure it might be applicable to other versions of it as well. Thank you so much for the patient listening.
Thank you, Shail. And this paper won Sante Vision Award in AIOS2025. So congratulations for that.
Thank you, sir.
Shail, which patients of dry ARMD will you not implant? these
sir,
EDOF IOS?
So, sir, I think right now we have just done a study and used only the early dry macular degeneration defined by the AREDS, which means the drusen size on OCT is less than 125 microns measured with the caliper. Probably in patients with mild to moderate is something that we are looking at to try, but definitely anything more than moderate dry RMD defined by retina surgeon, we would still be very, very skeptical in considering it, because they have a very high chance of conversion to a wet ARMD.
Okay.